Karen, I'm so glad you could be here today to talk about some history of Center for American Progress and the Affordable Care Act, because both of those things are celebrating birthdays. The ACA will turn 14 years old this month. That's when President Obama signed it into law, and CAP is also celebrating its 20th anniversary. What was it like when you first came to CAP? How big was the team, and what issues did the health team cover pre-ACA?
So when I first came to CAP, there was me, there was Meredith King, who was I think her title was research assistant, although she really did everything and was in charge. And Jean Lambrou was a fellow, and she was very engaged in what we did as well. So when I was here, I was the director of health policy, and we had a small but mighty team working on, at the time, what we just called healthcare reform to start with. Right now, I'm a senior research fellow at the Georgetown University's McCourt School of Public Policy in the Center for Health Insurance Reforms. And then I also work as a consultant to the policy department at the Robert Wood Johnson Foundation.
What sort of issues were you working on back then? Was it all health reform, or did you have any public health work, or drug pricing, anything else?
Yeah, it was really all health reform, but it was also
just a small thing, right?
Yeah, but I imagine CAP probably still does this too. You do kind of tie what you're doing to what's happening on the Hill, right? And one of the things that we worked really hard on right when I got to CAP, within the year, I guess, with Hurricane Katrina happened. And so we worked very hard for a while to try to have, kind of emergency Medicaid assistance available to people in Louisiana, which we did not manage to get through. But, sort of an example of you're working on your larger goal, but trying to use the opportunities that come up as well. We had work that we were doing, trying to, recruit candidates to really be engaged in health care. We were very interested in how the ACA was going to make a difference for communities of color. And I think some of that touched on, on health equity, obviously, but on, some of the ways the ACA was starting to change the kind of underlying racism of the healthcare system. I think we have a much better understanding of that now. And there's been a lot of work done in the time since then, but looking back and knowing, how engaged CAP was at the time is kind of exciting too.
And there's still obviously a lot of work to be done there too,
right,
to close those health disparities. In the time that I've been at CAP, one of the biggest changes, I think, for all of us was the pandemic. So we went from an organization that primarily thought about health as healthcare and carrying forward that legacy of CAP's work on the ACA to thinking about public health as it related to the pandemic, but also health as it relates to other issues that CAP works on. So we are now, I think, 6 people in the health team, with 2 that are dedicated to thinking about public health and public health systems. So we did a lot of work during the pandemic on analyzing what measures might help reduce the spread, masks, and then later with the advent of vaccines, coming up with a plan on how could you make a vaccine on the scale that was needed, and also distribute it to make sure that you are getting to communities that might not have as resilient a supply chain or have the money to store it or to set up clinics. So we were part of that effort, and now you continue to work on public health in all sorts of different ways, not just vaccines, but also thinking about things like the intersection of climate and health, how that disproportionately can affect communities of color who live in areas with less tree cover or might be more prone to floods or forest fires. And then thinking about things like lead pipes and how important it is for public money to improve the cleanliness of the air and the water for people's health throughout the country.
Lots of work to do there.
What brought you to CAP?
Well, really the lure of trying to bring health reform back onto the national agenda. That was something that CAP had already identified as a really top organizational priority. The woman who started the health team was leaving, and the plans that were in place and the ability to kind of opportunity to implement them and to take things further was really appealing. This was in 2005. So what we were looking at was trying to get health reform onto the national agenda in the 2008 presidential campaign. But we were, starting 3 years early and trying to make sure that it resonated in 2006.
I have a lot of admiration for what everybody did back pre-ACA to get that in the conversation. One of the things I find rewarding but also challenging about my job now of overseeing health and overseeing economic policy is that there's so much work that has to get done behind the scenes to finally have a public plan or a piece of legislation. There's so much coalition building, so much trying to reach people and industry and advocates to make sure you're on the same page. The importance of partners is also paramount. Mm-hmm. Who did you work with within CAP and outside CAP to make that big push for healthcare reform?
So one of our really key partners was the SEIU, and they had a group that was really focused on speaking on healthcare issues and organizing their members around healthcare. And we had a really productive partnership with them in the 2006 campaign. We also worked internally with the communications department, and a lot with a couple of polling experts who helped us kind of put together a poll that we took to various candidates and members, and to sort of hone our messaging on how really ripe the country was to take on this issue again. It was a long time after the Clinton health plan had not succeeded, and sort of in the ashes of that, the children's health insurance program came up, but was really about pushing it back on the agenda again. The problems had not gone away, and it took a lot of both internal effort and external partnerships to make that happen.
And a lot has happened since then. So now we're at the place where we've got 40 million people with coverage, thanks to ACA, record enrollment in the marketplaces at 21.3 million people covered. There's polling out that says, I think, which is a good reflection of how much better things are now, that people don't always know that it was the ACA that prevented insurance companies from denying people coverage or from rating women more. And it's a radically different world than it was pre-ACA. Can you remind us of how bad things were before the ACA?
Well,
and what brought that groundswell of advocacy to make that change?
Sure. Well, there had been, I think, awareness throughout that period of how many people lacked health insurance and how precarious holding health insurance could be and how important it was to have it. I think there had been the IOM studies in the early 2000s where, people who don't have health insurance live sicker and die younger was kind of one of the big takeaways from that. But we also had the kind of economic collapse and recession of 2008. And so while, number of people without health insurance had been sort of 42, 44 million. Suddenly in 2009, it was over 50 million people didn't have health insurance. They had lost their jobs and they didn't have someplace else to go. They could, pay to continue their employer coverage, but when you don't have a job, that's an awfully hard thing to do. So I think that was, in some ways a helpful crisis to kind of highlight once again how precarious our healthcare system was, and how important it was to make change.
I came to CAP sort of after the ACA was in place in 2017, and so my first few years at CAP were marked by trying to defend the ACA. One of the tactics that we use, in addition to the traditional analyses and forums and rallies that CAP had always used, was a lot more storytelling and actually asking individual people to come tell their stories. What is it like to be a parent of a disabled child who may not have health insurance or may face lifetime limits later, someone who needs really expensive medications to control cancer or chronic disease. Are there stories that you remember from the era of ACA passage that stick with you?
So CAP didn't really do storytelling then, but there certainly were stories that became kind of really key to the narrative. If I remember correctly, there was a young boy whose mother was uninsured and who, was, I think she passed away actually, but he was still like a spokesperson for how important it was to reform the healthcare system and make sure that people had insurance. And he was maybe 12 or 13 at the time. And I remember that both as being a poignant story and how, dedicated he was to doing that.
I'm always very touched when people are willing to bravely step up and talk about something so personal, because I think it's such a brave thing to do, but it's also for a cause that can help move votes, help move other people to understand why something like the ACA is so important.
No, absolutely. We did when I was at National Women's Law Center, and we were part of defending the ACA in the second Supreme Court case.
Mm-hmm.
We did a brief that basically featured stories just to really highlight how important the ACA was for women and their ability to get and keep health coverage.
You were at CAP during ACA's passage and signing. What was it like on those moments that were watershed moments for both CAP as well as obviously for the country?
Well, the night the ACA passed the House, it was fairly late, and it was also on a weekend, if I remember correctly. So I was at a gathering to watch everything that was on the floor, but it was really with advocates from all kinds of different groups, not just CAP. But the next morning we had a staff meeting, which we always had on Monday mornings, and I remember running late as I always do and walking in, and the entire staff meeting breaks out in applause, which was kind of a lovely moment. And of course it was everybody else who was there too had been such a great contributor to what was going on. But I also remember sort of stepping back a few months from that, the sort of daily calls that we would do and the updates that we would get regularly from people like Senator Daschle about, who had concerns and what they were and what were the kind of things that might be helpful to address them. And I remember being on, I think just, like texting or something about somebody for the first House vote, and could somebody talk to them? And somebody at one point was like, unless you're the president, you're not getting through at this point, so just back down. But it was, it was really an all hands on deck kind of effort from people like John Podesta and Tom Daschle to much of the communications department, and then the folks on the health team as well.
To me, that's one of the really special things about working at CAP, is that you have stellar policy staff, who can crunch numbers and do the legal analysis and understand how all these different government agencies can use their authorities to make the world better. But the communications arm here, the advocacy arm, the story bank that we now have, are all come together to make really strong campaigns for policy, like expanding coverage. And I feel blessed to work with such an incredible team.
Yeah.
What do you think is the future of health reform? What are you working on these days that builds upon the ACA, and what are gaps that you see that still need to be filled?
Well, I think that when I think of the ACA, I think of both the way it expanded coverage, but also the steps that it was trying to take to control costs. And while there have been, some really great models that have come out of the Center for Medicare and Medicaid Innovation, and certainly steps that have been taken, that feels like the not yet finished business to me. And in the time since the ACA passed, we've only seen an acceleration of consolidation in the healthcare system, hospitals buying, ambulatory care practices, the horizontal consolidation as well, which just makes it really hard for any payers, honestly, to be able to have control over prices. And we've known for a long time going back to, Uwe Reinhardt's article about it's the price is stupid, that's where, that's why we pay so much in the United States for healthcare. And that feels like the work needs to still go on and where we need to make more progress.
And that continues to be a thread of our work, that
Yeah.
consolidation, both horizontal of insurers and insurers, but also the increasing vertical consolidation
Yes.
of, hospitals owning doctors and insurance companies owning PBMs. One of the things that Health Team did a couple years ago was host a documentary screening here about hospital consolidation, insurance consolidation. There's a very deep body of literature showing that there's the price effect, but I think we will also have more traction if we can convince people there's real effects for patients too, not just for payers, that it hampers access to coverage. It can keep you from seeing the doctor that you want to see for your course of cancer treatment, and matters for workers too.
Well, and, just simply the impact on premiums. And as, workers pay a considerable share of their premiums and then trade off wages for health insurance as well. So that definitely feels like one of the unfinished pieces. And then we have not, sort of finished on coverage itself either. There are, signs of movement this spring, particularly in some states in the South, which is super exciting, but that work needs to get finished. And then there are folks who, even if the Medicaid expansion of the ACA is in, 50 states in the district, they will still not have options for health insurance. And so, particularly thinking of immigrants and, people who are either in what's called the 5-year bar, or people who are undocumented and not able to access insurance in other ways, figuring out how to expand coverage to them as well. And some states have already taken steps, and I think more will do the same.
We hope so too. We continue to work on Medicaid expansion and try to get coverage to those people in the 10 states that still are too poor to get marketplace coverage, which is such a terrible gap in the law that it turned out that way, that you could not qualify for subsidies because the expansion was supposed to fill it.
Yes.
And then we're also working on making sure that the enhanced premium subsidies for the marketplace coverage from the Inflation Reduction Act, which expires at the end of next year, 2025, gets extended as well. So that seems to have made a big difference for a lot of families, saving $800 per year on coverage per person, but also help boost coverage through the marketplaces as well.
Right, because enrollment can really see the effect of those enhanced subsidies in terms of people being able to enroll in coverage in the marketplace over the last few years.
Karen, you mentioned that employer-sponsored coverage is one area where prices and costs are going up, but we haven't had major reform for that. What do you think some solutions are there to help get the employer community and the advocacy community to coalesce more around affordability?
So I think it is a challenge to bring the employer community into this discussion, even though they pay a lot of money for health insurance. I think that they often have other priorities in terms of policy that are higher up on their list. Back when I was at CAP, we worked in a coalition with a couple of large employer groups. And I think, kind of recreating that kind of dynamic where you have advocates and major employers identifying what their shared goals are and then working on them together would go a long ways to helping figure out what the policy solutions are and then push those onto the agenda.
That sounds like a large task, but very important one.
Yes, exactly.
We're now 14 years past passage of the ACA. What are your hopes for the next 14 years?
Well, I think certainly that we get to a point where everybody has stable, continuous, affordable coverage, and that coverage enables them, importantly, to get the health care that they need. I think that's another piece that deserves a lot more attention, that while having an insurance card is a precondition, it's not the only one for getting the care that you need. And particularly because cost sharing can be so high, particularly in employer plans, but also in some of the marketplace plans as well, and can be a real barrier to access to care. I think another part is addressing some of the way that we organize and deliver healthcare. We talked a little bit earlier about all of the consolidation that we've seen in the system. I don't know if it's realistic to think that you can unwind some of those deals, but to understand and where the, forces like private equity, how they are reshaping our healthcare system, and to be able to, block, redirect, however you want to think of it, so that we don't have a healthcare system that is driven so much by how can assets and profit be extracted from it, but more is focusing on how do we deliver high value, good quality care. There's a lot of work that's been done around how do you pay for quality, and that can certainly be built on as well. But I think when the financial incentives are really driven by investors, it's, even those kind of financial incentives for providers can't overcome kind of those larger drivers.
Those are some of my hopes too. We keep working on, as you said, trying to tie payment more to value that people are getting in healthcare. So we are, I'm very proud of the role that CAP had among many, many others in trying to, and succeeding in getting Medicare negotiation for prescription drugs. We've written about how there's more that could be done to tie drug pricing to value. I think more that needs to be done to think about how to slow and also protecting against the harms of consolidation, whether that's empowering state governments to with better resources for merger review, but also just making sure that healthcare agencies that really have the interests of patients and consumers in mind are part of that review process, with the idea that there's something special about healthcare. It should be a right, and if people don't have access to the care they need, it can affect their health. It can, people can die from not having the drugs or the treatment that they need.
Right.
Thank you so much for being here with me today, Karen. It's wonderful hearing about CAP's history and also what you did back to help formulate the ACA and get it passed, and what you're working on today to carry that forward.
Oh, it's terrific to be here. Thank you so much, Emily.
So glad you could come back.
Thank you.